Hi, everybody. So we're going to be starting our afternoon report today. So we have our 76-year-old female with a past medical history of breast cancer, status post left mastectomy in 1998, hypertension, glaucoma, recently diagnosed mild cognitive impairment, presenting with a 50-pound weight loss since the last 5 months. She's also noted to have decreased appetite since the last 5 months and has been eating only one meal a day, and she has associated fatigue. Any questions at this point?
What's her baseline functional status? I know she was diagnosed with mild cognitive impairment, but it's something like worse than that.
So she's completely independent of her ADLs and IADLs. She's able to ambulate. She doesn't use an assisted device. She's pretty functional for a 76-year-old.
One question, Pratyusha. Where are you seeing the patient?
Inpatient.
Inpatient, okay.
Inpatient. Okay, so we can go. We have her past medical history. She was diagnosed with breast cancer in 1998. She has hypertension, glaucoma, early dementia. Her surgical history is notable for left mastectomy with reconstructive surgery. Her medications are for her for losartan 50, amlodipine 5 for her hypertension, and eye drops for glaucoma, and donepezil 5 milligrams. And she has no known drug allergies. Social history, she's a retired worker, lives alone, independent of ADLs. She also tracks her steps. She makes sure she walks 10K steps every day. She quit smoking 30 years ago. She quit alcohol 10 years ago. And there's no relevant family history. Any other questions at this point?
Any blood in the stools? Any worsening cough or hemoptysis?
No.
Okay. Any other symptoms like besides just like the weight loss, such as like early satiety or any abdominal pain?
No abdominal pain, no early satiety, no.
Does she have trouble sleeping?
No.
So, sorry, go ahead, Christopher.
Oh, no, I was going to ask for night sweats.
No night sweats.
So Sana is asking in the chat, any trouble swallowing?
No trouble swallowing.
When she was diagnosed with dementia?
She was diagnosed 6 months ago. No fever, no chills, no cough.
So it's not considered early dementia, isn't it? Because I saw in the history that she was diagnosed with early dementia. I don't know, do you mean that early stage of dementia or?
Yeah, early stage
onset,
of dementia.
Early stage.
Yeah. The patient is from New York. Oh, I see Frida asked a question. Does she follow up with the oncology? No, not that I know. The patient's from New York.
Does she have history of depression, or is she depressed?
Not any history that we know of. So her family did provide some history that she forgets things. She's been having some problems with her memory, but most of the time she's able to take care of herself. The family comes in and checks up on her like on a weekly to like maybe a couple of days a week. She's very sharp. Her history, she's able to give us a good history. No other history that she was able to tell us, or the family told us at this point. From what we know, she is in remission from her breast cancer. We don't have better history. We were told that she had a lump and had a mastectomy after that. She got radiation, but no chemo, and no known thyroid problems that we know of. No urinary symptoms that we were able to elicit.
I think Christopher, there we go. He accidentally private messaged me, but yes, no, it's in the chat for everyone.
Yes, patient is up to date with all her screenings. She never had a lung CT because she quit smoking 30 years ago, and she doesn't qualify for a screen. She did have a colonoscopy. She's 76 years old. Yeah, I can bring the slide back up.
Okay, I think we can move forward to the next slide.
So the rest of her ROS review of systems negative. Then we have her vital signs and physical exam. Her vital signs: blood pressure 134/82, heart rate of 86, respiratory 16. She's afebrile. She's starting okay. She's 5'3" and her weight is 49. So in her physical exam, her relevant findings were that she's very frail, elderly appearing. She has temporal wasting, and she has like a left breast reconstruction with like a scar, but no other significant findings. So anybody would like to take a shot at the problem statement?
And also let us know if you have any questions about the physical exam as well, if there's anything else you want to know about the physical.
Yes.
You're unmuted, Christopher. I'm not sure if you had something to say. Sani is asking about the get up and go test, if it was performed or not.
Yes, it was, and she passed, so it's basically less than 12 seconds.
We saw some of those tests in our fall lecture as well. So
yeah, it's kind of very good we had the lecture because things are similar here too.
So
and even the 30-second share test, she passed. She's very active physically.
perfect. So I guess, Jonathan, do you want to go ahead and perform a summary statement, and Pratyusha, if you want to help him going back to the HPI, or Dr. A, do you have a question or? Okay.
So we have an elderly woman with a history of breast cancer in remission, recently diagnosed mild cognitive impairment, presenting with a 5-month history of weight loss, 50-pound weight loss, unintentional, I guess.
Yeah, that's great. So that's exactly my statement too. The same elderly female, breast cancer, early dementia with significant weight loss. So we have this patient who's admitted. So what would we want to do? Like, how would we like to work it up? Or what do you think our differential is at this point?
So Frida is worried about cancer because of her age. Also, we have a remote history, a little bit unclear, that we have. So what would you want to do for that, Frida, for the workup? Like,
True. Total body CT, correct?
Is that really
Any
what we want to do, a total body CT?
Including toes.
Lab, CT chest, abdomen, pelvis. Could be cancer, but not necessarily breast. Can be lung or colon cancer. That's what Christopher is saying. CBC and a CMP. Yeah.
So can you tell us more about her early dementia? Because at one point someone said MCI, then someone said early dementia, and I think you really need to know what that really is, because that could be a cause of her weight loss. And it's not really something we see in early dementia because people usually remember to eat then.
So the only history that we don't have access to her primary care notes, who she does follow up with pretty regularly. But per the family, the history we got was that she was just diagnosed with early dementia because she's been forgetting things. And she was started on Aricept, and that's the only history we have about the dementia. But when she came to the inpatient hospital, we didn't find that she was maybe like not altered or she was forgetting things. She was pretty sharp and she was able to give us a good history. So we didn't notice any findings or anything that we could investigate. Any joint pains, fevers. She does have like some mild arthritis of her knees, and apart from that, no significant joint pains, no fever, no recent travel. No, her gait's good. She's walking uh, without support, without any assisted device. She has no tremors, no rigidity. We Uh, yes, this is old arthritis before the onset of weight loss, but it's like very minimal. Again, the patient does not have any physical disability or any restrictions because of her arthritis.
Okay, so going back to the, okay, Fatma has a question.
Other differentials. So Fatma saying we have rapidly progressive dementia, depression because history of psychological stress, thyroid abnormalities. Great, all great differentials.
Yeah, I think Jonathan had mentioned it as well. You know, the history of depression is very important. Also, if anyone like even screen her, you know, just taking that time to do it, it can, you know, end up having a very similar presentation to dementia, cognitive impairment, definitely something in the differential. So as of now, I guess for workup, people want to get basic labs, CBC, CMP, a TSH, I think is reasonable. CBC, I think. So what would also GI disease? Sorry, Frida saying large ulcers or malabsorption, but she doesn't have those symptoms yet. But basically, I would just want to not skim through the workup necessarily. Kind of like talk a little bit about what we would be seeing in the labs and the imaging, what we're looking for, right? And this differential, I think the main point is this person ended up having like a 50-pound weight loss in the last 5 months. So this is definitely far from normal. And we need to start thinking about like what specifically we could see. You know, CBC, I would start looking for, you know, anemia of chronic disease, for example, or malnutrition. You know, if this patient has the cognitive impairment, you have like even vitamin B12 deficiency that would show up in the CBC. In terms of BMP, CMP, you like, again, this person just lost a ton of weight in a very short amount of time. I would want to make sure that there's no like electrolyte derangements as well. And again, the chronic disease could tell us about some inflammatory disorders that this patient might potentially have, even though she doesn't necessarily have the symptoms. In terms of imaging, given the history of cancer and I guess the extremely rapid weight loss and the age, I think it's definitely not unreasonable to do a CT. If you had a much lower suspicion, you could start thinking about just an imaging of the chest as well, depending on the symptomatology of the patient. to look for, things like TB or even just malignancy as well, her history of lung cancer. But and sometimes you can consider infection as the differential, but this patient seems to have a different picture as well. So Pratyusha, I don't know if you want to go back to the questions in the chat.
So we can go ahead with the lab findings.
Can I just ask, I'm sorry if I missed this, but did we talk about how her appetite is, what her intake has been?
Yeah, so she did mention about loss of appetite and that she's been having maybe a 1 meal a day.
Okay.
Yeah. I think we have somebody in the chat mentioning about GDS, which is the Geriatric Depression Scale. We'll get to that eventually, but she sounds like she has access to foods, meds, but the description of her function, cognitive impairments, and family checking. Yes, SDH screening, great. Yes, so she's she does not have any food insecurity, but that's a great point to pick it up. Okay. So we were thinking when we got the patient thinking about the same lines of the differential. So we went with the same workups that all of you mentioned. We got like a CBC, a CMP, a trope was thrown in, which was all normal. We had other, like a UA was done, which was negative. Her TSH was normal, Y20 normal, RPR was done, which is normal, B12 was normal as well. And in terms of the other workup, she got an EKG done, which is not significant, normal. We had a chest x-ray again, trying to rule out any infections in her again, which was like pretty unremarkable. And we had to have a CT chest and abdomen because we were also thinking along the same lines of cancer. Was it like breast cancer or a new cancer acting up? So we got a CT chest, abdomen, pelvis with contrast. And this was our most significant finding. So she had a very large uterine mass, which was like 8 into 6.8 centimeters in size. And the radiology read was it a fibroid versus endometrial cancer? And they suggested like a pelvic MRI. And coming to the differentials, well, we did have the same differentials: cancer, was it metastasis, any infections, chronic TB, UTIs, pneumonia, any chronic diseases, any mental health illness, depression, psychosis, rheumatological or autoimmune diseases, and medications. So medications was the other differential, polypharmacy. So our patient, just to have a broad diagnosis for her at this point, so she is diagnosed with failure to thrive. So we're just going to talk a little bit about failure to thrive before we go back to her. So what is failure to thrive? It's defined as a syndrome of weight loss greater than 5% of baseline. There's decreased appetite, poor nutrition, physical inactivity. It's also associated with dehydration, depressive symptoms, impaired immune function, and low cholesterol. So there are three main components to failure to thrive: physical frailty, disability, and impaired neuropsychiatric function. So just this chart kind of summarizes failure to thrive. It's like one of the most common diagnoses we see. So I just thought we could just talk about it. So we can see frailty, it says malnutrition, weight loss, poor physical function, and disability. All the comorbidities can affect a patient's ADLs, especially in the elderly. It can be COPD, CHF, any malignancy, diabetes, arthritis. Psychosocial factors. This is a very important aspect, especially in the elderly, which is isolation, any grief for the loss of the long-term partners, any financial issues, abuse, elder abuse, or neglect. And medications definitely always play a role. So what are the common causes of failure to thrive? So it's the same causes we've just spoken about: diseases. Important to keep in mind: dementia, delirium, any substance abuse, drugs, dysphagia, deafness, depression, desertion by family, social isolation, destitution, and despair. So, how do we evaluate a failure to thrive? So, we just had a great lecture about falls, which is very similar to how we evaluate in the elderly failure to thrive. We do have to take a very good history. In the physical exam, we do the up and go test that we just spoke about, psychological assessment. So, the geriatric depression scale is a great tool. It's slightly different from a regular Phqn questions. This is an example of a short form for geriatric depression scale. It has 15 questions, and like any positive point more than indicates 1 point, and more than 5. If you score more than 5, then you can it indicates depression. So these are like questions like, are you satisfied with your life? Have you dropped any activities? Do you get bored? Are you in good spirits? It's kind of very similar to PHQ-9, but it's a little more towards the focus towards the geriatric population. Going back to our evaluation, functional ability or the physical activity a person does. And also to keep in mind at this stage, I know somebody asked if the patient had difficulty swallowing, which is also important. It's good to evaluate for any oral pathology, any poor dentition or ill-fitting dentures. That's also important to evaluate for people with any failure to thrive on nutritional needs. Polypharmacy, medication reviews is so important in the elderly. We know about the Beers criteria, the different drugs which may be harmful. So it's very important not just to review the prescribed medication, but also over-the-counter medications that most of our patient population take. Coming to other socioeconomic factors, we discussed isolation in the elderly, food insecurity, and housing issues. That's also very important, especially in the elderly. In coming to nutritional assessment, yes, we do need to evaluate about the nutritional needs, if they have any dietary restrictions, if there's anything that their chronic diseases are allow a patient to follow a specific diet. But again, important is the patient able to feed themselves? Do they need assistance? So that's also something that needs to be evaluated. Um, so what are the common labs we do for workup? Everybody mentioned this. It's the CBC, metabolic panel, thyroid, TSH, vitamin B12, folate, albumin, and cholesterol. Now, these two tests indicate malnutrition. If you have very low albumin and low cholesterol, total cholesterol, it's a marker for malnutrition. And we also check for vitamin D levels, especially in patients who have a history of falls. And the workup also changes based on that individual patient and the comorbidities they may be having. So how do you manage all these conditions? And I like this chart because it kind of gives a brief idea about what are the most common etiologies and how do you treat them. So depression is a very common reason for failure to thrive, and obviously treat with therapy, antidepressants. Malnutrition, we discussed, you all treat any oral pathology, any dietary restrictions, and help in feedings if needed. For cognitive impairment, dementia. So dementia is a major contributor of failure to thrive in the elderly, and it is very important to distinguish and identify delirium, which is acute and can be easily treated and reversed. And over here it says about treating depression, malnutrition, infection, anything can cause cognitive impairment. And functional impairment, we can help with like physical therapy, occupational therapy. So since if a response is positive, continue to treat. So a positive response is defined as achievement of set pre-treatment goals. Now, what does this mean? If we have a 90-year-old patient, we can expect them to be running 40 miles a day. So their goal can be as simple as I want to be independent of my ADLs. So whatever a patient individual's goal is, if they're able to achieve that, and that's what we expect a positive response is. And again, over here now comes the importance of having a goals of care discussion with not just the patient but also the family and the caregivers, because if they get admitted, or this is the time when the question arises like how much or how much to what extent they want to be treated, what are their wishes and their long-term goals, and it's very important to have that discussion, and sometimes it can even lead to end of life and hospice options. um, okay. um, I just brought this slide in because failure to thrive in the elderly is mostly an outpatient management. Um, there are very few reasons that would need inpatient criteria. And I guess the top two are like if there is any acute etiology, like if the patient is septic, they're unable to tolerate any PO, they have intractable nausea, vomiting, and they need IV medications, that would be a very appropriate admission. And also sometimes social reasons, if the patient is unable to take care of themselves, or this caregiver burnout, or they're waiting long-term care facility, that would also be like an admission. But failure to thrive is mostly managed as an outpatient. Um, so just wanted to talk a little about the role of appetite stimulants. We see it very commonly here in inpatient that if a patient has a loss of appetite to prescribe appetite stimulants. So I just wanted to talk about the two commonly used appetite stimulants, which is megestrol and dronabinol. So megestrol has as actually more indicated in like cancer related anorexia or cachexia than for failure to thrive in elderly. It is actually shown to have more adverse effects and not shown to have any significant improvement in the quality of life in the elderly. And some of the most common adverse effects are thrombosis, fluid retention, and death. And it is included in the Pierce criteria. Whereas dronabinol is also mostly used for anorexia, cachexia, and AIDS patients more than in elderly. There's unclear evidence about its use or its benefit, so it's more like provider um, based provider preference if they do want to prescribe it. But it's important to keep in mind the side effects such as neuropsychiatric, like especially in the elderly, they have paranoia, hallucinations, abnormal thinking, and GI upset is another common um, side effect. Artificial nutrition. So what is the role of feeding tubes, NG tube, PEG tube in patients with advanced dementia or in failure to thrive? So, well, it depends mainly on two core principles, which is do no harm and what would the patient want. So advanced dementia is like the leading cause of mortality in patients with advanced dementia is dysphagia and aspiration. So per AGS, which is the American Geriatric Society, feeding tubes have not shown to improve their functional status or quality of life. They do not prevent weight loss or aspirations, which is the cause of death. So it is known to cause more harm than benefits, such as infections, increased agitation, and pressure ulcers. Um, the recommended method to enhance nutrition is by assisted oral feeding rather than artificial nutrition. But again, it all depends on the goals of care conversation. What would the patient want, which is one of the core principles. So coming back to our patient, so after probing the patient further, she revealed that patient is aware about fibroids that she had for many years and that she follows up with GYN. She's had the fibroids. I mean, the last imaging we have of the fibroids was in 2016 when there was a transvaginal ultrasound, which showed the same similar size of the fibroids. She has not had any other symptoms from the fibroids, no abnormal bleeding, no postmenopausal bleeding, or any other symptom as a result of it. And the plan for the GYNs to continue to monitor it. And if she had any abnormal bleeding, they would want it to biopsy and then remove it. But it's been stable since many years. So the CAT scan finding was a normal fibroid. It was not cancer. Um, and so the cause of her loss of appetite is Aricept or donepezil that she was recently started on. So patient was started on donepezil 6 months ago when she was diagnosed with her early dementia. And the loss of appetite is a very well-known side effect of donepezil, and symptoms started out on the same time. So we stopped her donepezil because it looks like it's causing her more harm than benefit, and it's an anticholinergic. But as we say again, failure to thrive is not just uh, a single reason, or it's like more multifactorial. And the other reason, other contributing factors can definitely be her mild depression. And everybody was right in it because we did a GDS score eventually, and she scored a 7, which was basically she's diagnosed with mild depression. So we started her on mirtazapine as well. So to have a dual benefit of treating her depression as well as acting as an appetite stimulant. And her early dementia or mild cognitive impairment could definitely have been playing a role if she's been forgetting to eat. And that is it. Any questions?
So I'm just gonna say, in reality, there was really no indication to do that CAT scan.
Yes.
Because it's not really generally recommended for weight loss unless you have some clinical sign or symptom that's pointing you in a direction to do directed imaging. All this pan scanning and stuff, because we feel like we have to do something, is really unrevealing 99% of the time.
Yeah.
And I think too often we say this one patient that we found a cancer in is the reason for us to do it, and everybody else. And you really have to fight that, kind of, reasoning, because that is not good clinical reasoning.
Yes, absolutely agree. And I think the only reason we did it because she was admitted. And again, this patient does not need to be admitted. She didn't fit with any criteria for admission.
But I would say that's an even worse reason to do it, just because you inappropriately admitted her, then start scanning her, right? And doing all these expensive tests that we can do in the hospital just because they're there. And we see that happen all the time. Oh my God, we admitted them, so we have to do something. So let's, pan scan them. And then we start finding all these things that don't really mean anything. So, I just realized, we all realize, oh my God, we want to do something at night when they're admitted. So let's just start ordering things. And I think you really want to kind of step back and stop yourself from doing that if you can.
Yeah, absolutely.
Hey, this is Dr. Kangsha, Dr. Sharma. First time joining you guys. So very, very, very well put together talk. It was very nicely done and I thoroughly enjoyed it. So my question is, when was her last PCP follow-up? I mean, if it's going on for 5 months, did she go to the PCP regarding the same complaints? Or I missed the initial presentation, was she brought into the ER by her family? Or what was done before she came to the ER?
So she was brought into the ER by her family, basically her son, because their family checks up on her once a week, and then the son saw her and felt that, okay, she's been losing weight for a long time and she needs to go to the ER. So there was no acute event that triggered them to bring the patient to the ED, and the patient didn't want to be there. She's like, I'm totally fine. I don't want to be here.
Majority of
yeah, majority of the people who come here. But she saw her PCP 6 months ago. That was when the donepezil was started. That was her last PCP visit. But she hasn't.
So there was no a follow-up with PCP because these kind of situation where you're having this chronic loss, weight loss and loss of appetite. It's a very it's not acute like you said. So it's a very good setting for an outpatient workup. Yes, in this case, there seemed to be no cancer pathology leading to her weight loss. But in an elderly patient, you can also have hematological malignancies like CLL, that can be very easily picked up just by, CBC, and then it can lead to further workup. So because, it's easier for the families to just drive patients to the ER, and, when there is a pretty significant weight loss, the ER's knee-jerk reflex is, let's admit, hope we are not missing out on a malignancy, given the fact that, 20, 30, 40 years ago, there was some malignancy. So since we did the pan scan and saw there was, we didn't find anything. It could have been a very different situation where we could have seen some mets in the spine, and so it can go either way. But I agree to like just start like, you know, baby steps with like doing the basic test. It could have been just hypothyroidism, doing the depression and you know, test and seeing that she's depressed, getting more. I am a true like strong believer in getting like collaterals from the family. Post-COVID, so many elderly people who had a very strong camaraderie, going out, having dinners, lunch, and having a social life, were like forced to live inside their house. And many people end up being depressed and stop eating and had failure to thrive. So getting that information, I know it's hard, especially from the patients themselves, because, you know, they have like some dementia going on. They don't want to be there. They're tired of answering your questions. So talking to the family, friends, whoever you can get hold of is very, very important and like helpful.
Yeah, thank you. It's really helpful.
Hi, Pratyusha, this is Subrat.
Sorry, Subrat, you're unmuted. I don't know if you have a comment.
Can you hear me now?
Softly, but yes.
Yeah.
Oh, okay. Hi, Pratyusha. Thanks for the presentation. It's pretty nice. I just had this question. Dr. Andili did mention about not scanning patients, which I definitely agree that we probably overscan. But given the patient has such a huge weight loss, like 50 pounds, and there's some temporal wasting. I remember reading that temporal wasting is slightly more, I won't say specific, but it kind of is seen more in like cancer patients. Does it change anything?
I think the patient was also very malnourished because she's not
Okay.
been eating, and that could have also contributed to the temporal wasting.
Yeah, I don't think it is more specific. Do you have, like, if you can bring us some data, we'd love to see that, like if it is like, you know, more leading toward cancer, because any sort of malnutrition can lead to like temporal wasting. It's basically like losing muscle mass, and it is very evident on the temporal area. But yes, hindsight is always 2020, right? So this time, you know, we didn't pick up anything, but like there are many cases when we do. So if it is not very convincing, you know, diagnosis with the whatever data you have, I mean, the best next step would be to scan, even though we tend to overscan. You can also, like, you know, figure out like, oh, that's something very important. Somebody had a cancer history. You know, you can definitely look deeper and ask like when was the last time the patient had mammogram done? You know, and that's in a situation you would be like, okay, it was done last year, you know, everything was okay. So it's less likely that now, you know, the patient has a metastatic disease. So I say, like, you know, once you have answers, it's good. If you don't, I don't think it's bad idea to go ahead with imaging.
Dr. Sharma, coming back to the temporal wasting, I'll definitely try to find out. I read a paper regarding how it is like interleukin and inflammation dependent, and that's why it specifically affects the muscle mass. But I'll definitely try to find that paper. But
yeah, that would be very
something
interesting.
that kind of comes to my mind. Yeah. But yeah, I understand.
Yeah, I also think at the end of the day, you know, this patient has gone without a scan for 5 months. It could have definitely waited like a few more days, you know, before, like we said, getting collateral, like was already mentioned from the family, but also the PCP, like was mentioned, the onc history that we didn't know well, we could have found that out as well, and that maybe might have reassured us a little bit. I do have one question, Pratyusha. I guess, when did this case present to you? Like, do you have any follow-ups? Like, has the patient improved at all with this management, or like, what did you just recently see here?
It was a recent case, so I don't have a follow-up. Yeah.
Also, like many patients' family will try to convince you to give them appetite stimulants. So what's your take from, like, you know, you mentioned there are many side effects and they don't, you know, the harm is to, like, you know, benefit ratio, not that favorable. So like, what you gonna tell to the family members when they push it? Like, you know, why can't you make her like eat more and help her with appetite?
I think it's very individual specific, or this is just my opinion, because it depends on what the patient has. And if you find a cause, like for her in this case, we do think Aricept is the cause of a loss of appetite. And we're hoping that once we stopped the Aricept, her appetite would improve, which would help her eat more and get better. But it also depends on the cause. Like we also added mirtazapine. I feel that's like a good combination, like with her depression and her appetite stimulant. I'm not really that sure about dronabinol because of the side effects. So if it's a patient who's like pretty healthy, then maybe it depends on how the patient would respond. And again, the whole discussion is between risk versus benefit. Do we think it's actually going to benefit or cause more harm?
Yeah, and speaking from more of a hybrid, like I was also coming in, there was a lot of megas used in our HIV patients. And so a lot of the patients they wanted, that's what they were what they were used to. And definitely most of them of all of my patients are out of it now, they're gone from it. Ensure is a big thing that people want. I think in the end, it's what's already been mentioned is really talking to a primary care physician and really getting like what's going on, because you're the one that has the longitudinal relationship, not just with the patient, but also with the family. I feel a lot of times we don't get reached out a lot and this is something I talked to Dr. Singh a lot with, but it's that longitudinal relationship, not just with the patient, but with the family that matters. And mirtazapine was a great point, Pratyusha, because that's something that I have utilized, but I think that depends on the history that you're getting, especially with the COVID impact. Unfortunately, a lot of my I don't say elderly, more experienced patients have really kind of debilitated. And a lot of it is from depression, anxiety. And one of the side effects of mirtazapine that I was told is that you end up like having more of an appetite, but that could be just because your depression is also improving. So it's like that kind of, counterattack. But regardless, like I think it's getting down to history. When asked about like, oh, if the family's asking you for appetite stimulation, I say get your history, collateral information from your primary care physician, from your family, and really get into like what's going on and figure out like what's happened. Because I've gotten the opposite. I don't want to feel hungry all the time because someone was asking me an appetite, and I said why, and then I realized that the person was suffering from food insecurity, and that's the reason why they wanted something that wasn't going to make them hungry anymore. And so that's what I would say. But unfortunately I joined late, so I didn't get to see the whole case. But great discussion at the end though.
And I'll just add like one last thing about like, and you roughly touched on it about the hospice. I know it's like a very, difficult thing to like, for the families and like to accept. And even like we also take pretty long time to actually like, come to that point and like open that conversation. But like if you have tried all, like you showed the flow chart, like if there is an infection treated, if there is any metabolic derangement treated, or like if you have tried everything, you have tried to treat the depression if that's present and nothing works, then that's something we should be able to like move forward to, because it's just like a rolling ball. You can just like move them to acute rehab, saying that, oh, they're frail, they did not pass PT assessment, they're recommending SAR, they go to SAR, they keep them for 2 weeks, and they go back home, and then they come right back in to the ER. So like somebody has to break that cycle, because sending them to SAR because they're so frail, it's just like putting a Band-Aid, and then they'll be right back to the ER. So, this patient was old, usually failure to thrive. We, start with like failure to thrive in elderly. We said that, but in reality, you can also see failure to thrive in a younger patient too. And then there are like 3 aspects of it, like, frailty, disability, and neurocognitive impairment. These are 3 aspects, as well as they are actually, they are interrelated as well. Like if a young person from cardiomyopathy has like very severe CHF, and they're through with all the treatment, and, they're at the end stage, that can lead to like frailty, that can lead to disability, that can lead to like depression, neurocognitive impairment. So that can very much happen in a younger patient too. Then again, like, it sounds bizarre, like failure to thrive in a young patient, but can happen. And again, you can, like, after trying everything, you can open the conversation about hospice too. I have done this, felt very awkward in the beginning of my training, and that I got comfortable with it.
Yeah. Absolutely. I also think that's a great conversation to be having with your primary care or like any physician you've had like a long-term relationship with. I think that would be ideal. But sometimes, as you mentioned, in the inpatient, people just have a cycle between SOR and inpatient. And that would be like a great, an awkward, but a neat
That's
conversation.
best to be like done in an outpatient setting, that they have a long-term relationship.
And actually, it's very, the PAB care team is so amazing here that you can actually, something I did with 2 of my patients, you can actually arrange for an outpatient, that you don't actually have to admit someone just to be able to have hospice services. You can do it outpatient, because that's what I didn't want to happen, is for my patient to have to even be in the hospital. And the family was able to have the patient at home with services provided by the hospice team. So it's something just to be aware that you could do it outpatient and not even have the patient go into the hospital.
And you can do it without actually consulting PAL care if you're working with visiting nurse, because they have palliative care through visiting nurse, and they'll do the whole evaluation for you, including hospice. So you don't have to send them to like the private PAL care first if you're involved with visiting nurse. And I think, we forget the visiting nurse services, they can be your extension into the home. So a lot of things that you want to do that we bring people in the hospital and VNS can do for you, and they can call you to talk about the patient and stuff, do home assessments. And I think if you're doing primary care, the better relationship you have with the VNS providers. Like when I had my practice, I always gave them my cell phone because I wanted the nurses to call me. I wanted to make it as easy as possible for them to reach me, because really then you have someone who can check on the patient on a regular basis, and it just makes it so much easier when they come to your office because you've gotten intervening information from them, the social worker, etc.
Okay.
That was great, Pratyusha.
Yes, thank you so much, Pratyusha. Definitely something.
Fantastic primary care topic.
I was gonna say something we actually see, so it's really nice to have an overview. And so thank you so much for preparing it. Thank you so much, Dr. Sharma, as well, for joining us for the
Thank you very much,
conversation. And so with that, we conclude our academic half day. This lecture will be uploaded, and enjoy the rest of your day.
Now also check vision and hearing.
Yes, very
Yes.
important.
That too.
Yeah.
All right,
Thanks,
guys.
everybody.
Thank you.